Welcome to Module 5, where we will review Appendix E of the Nova Scotia Standards of Practice for Non-Sterile Compounding. Upon completion of this module, you will be able to explain the difference between a compounding record and a master formulation record, create a master formulation record from scratch, determine beyond use dates for compounds, explain verification requirements, and develop quality control procedures for compounding. Compounding must be done in accordance with a master formulation record, or MFR. An MFR is a detailed record of ingredients and procedures that describe how the compound should be made. It is unique to each compound and each pharmacy. There is no generic master formulation record that can be used in all pharmacy settings because every site is different. For example, risk mitigation strategies and precautions may be different depending on staffing or workflow in one pharmacy versus another. The MFR ensures that each time a compound is made, regardless of who the compounder is, it is prepared in the same way, with the same quality assurance measures in place, and results in an end product that looks the same each time. An MFR must be developed for every compound prepared in a pharmacy and must be referenced each time that compound is made. Before preparing a compound, the compounder is responsible for ensuring that the MFR is current and has been reviewed in the last 12 months. If this hasn't been done, a pharmacist or pharmacy technician must review and update the MFR before proceeding with the compound. There was a recent medication incident in British Columbia involving a 5-year-old boy who overdosed on a clonidine compound suspension that was 14 times stronger than prescribed. It was found that the pharmacy had no standard policies or procedures in place for compounding, and that the pharmacist did not perform an accurate final check of the drug. If this pharmacy had standard operating procedures in place and an MFR to follow with quality checks, it is very likely that this error could have been prevented. Appendix E lists the required information that must be included in an MFR. We will review each item in this module and walk through developing an MFR for a simple compound. Remember, most of the information required in an MFR is probably already included in your compound files. Before walking through the development of a master formulation record, it is important to review the differences between a master formulation record and a compounding record. When comparing an MFR and a compounding record, the main difference is that one MFR is created and referenced each time a compound is made, but there is a new compounding record created each time that compound is prepared and dispensed. The MFR contains general information and instructions to follow and acts as a recipe or guide, but the compounding record contains information specific to an individual prescription and is retained as part of the patient record. The compounding record must reference the MFR. In other words, you need to review the MFR every time you prepare a compound and document this on your compounding record. An MFR lists ingredients, quantities, and calculations for a generic amount determined by the individual who developed it. The quantity listed will not change regardless of what quantity is dispensed for a prescription. On the other hand, compounding records include the quantities used to prepare each individual prescription and would change depending on the amount dispensed. The quantities and calculations included in the MFR can be referenced to make sure the quantities that print on each prescription-specific compounding record are correct. Another difference is that the beyond use date is listed in a non-specific way in the MFR, for example, 60 days. The compounding record would indicate the actual beyond use date, which would be 60 days from the preparation date. The MFR includes the names of the professionals who created and verified it, which wouldn't change until it is reviewed and updated. The compounding record would include the names of the staff members who prepared and verified that specific prescription and may change each time the compound is made. Think about a single compound, for example, hydrocortisone 1% in clotrimodone. Every time this compound is made, the same MFR would be referenced to guide the compounder through the process, but a new compounding record would be created for each individual prescription dispensed. Although an MFR and compounding record are two different things, it is possible to combine them. Many pharmacy systems will allow for the information required in an MFR to be included in the instructions section of the compounding record or worksheet that prints automatically when a prescription is processed. There is no requirement to have paper copies of MFRs to be kept together in the dispensary. If your MFR is included in your compounding record, all documentation can be stored together on the patient file with the prescription record. This is an example of a compounding record for lansoprazole 3 mg per ml suspension. It shows the actual quantities of ingredients used to make a specific prescription number that was 100 ml in total. Before proceeding to make this compound, the compounder is required to review the MFR. Some aspects of the MFR are already included on this compounding record, such as the mixture name, the ingredients, the compounding instructions, and the beyond use date. There are also lots of things missing. There is not one single way to develop or document the different elements of the MFR. Different pharmacies may have different formats, or they may store documentation in a different way, but the important thing is that it includes all of the elements listed in Appendix E, and the information is readily available to be reviewed by the compounder. One option would be to include all information required in an MFR in the instructions of the compound file so that it prints automatically each time a compound is processed. If you didn't want the entire MFR to print each time a compound is processed, you could use the comments section to record each element of the MFR. You can see in the example that different elements are listed as their own topic. The compounder can review the information quickly when stored in this format. One way to avoid paper copies of MFRs and safety data sheets around the pharmacy that could get misplaced and cause clutter is storing everything electronically in the compound file under Documents. In this example, the pharmacy has applicable safety data sheets and the reference formula stored under Documents. You could also keep a copy of the MFR here, where it could be referenced or printed with each prescription. Appendix E of the Standards of Practice lists information that should be included in the MFR. We will walk through each item on this list for a simple compound of hydrocortisone 1% in clotrimodone cream. First, the MFR must indicate the date it was created and last updated. As previously mentioned, before preparing the compound, staff must confirm that the MFR has been updated within the previous 12 months. The MFR must be created by a pharmacist or pharmacy technician. This would usually be the compounding supervisor, but could be another pharmacist or technician working when a new compound prescription is received. Next on the list is the name of the compound. It is important to consider NSCP labeling requirements when deciding on a compound name. Label requirements for compounded drugs must include, in addition to other labeling requirements, the name of the product or a list of active ingredients and strength. Generic names like Magic Mouthwash No. 1 are not appropriate. It is important that you can tell what is in the compound by reading the label. If the name doesn't fit, you may need to use abbreviations, and this is okay as long as the compound is still able to be identified by another pharmacy if needed. For example, in the pharmacy world, HC is pretty much universally known as hydrocortisone, so it wouldn't be unreasonable to abbreviate hydrocortisone to HC in a compound name. The dosage form is also required on the MFR, and in this case, it is a cream. The expected yield is the generic or standard quantity you decide to use for your MFR. 100 grams is a quantity that can be referenced easily when comparing quantities on your compounding record. If using an already established formula to develop your MFR, for example, from the IWK or Sick Kids websites, you should pay special attention to the base quantity listed in the original formula to ensure the final concentration of the preparation is correct. For example, if you put a base quantity of 100 mils intending to make a 25 milligram per mil product, but in the original formula, the base quantity was 120 mils, and you didn't adjust the quantities of the other ingredients, you will end up with a 30 milligram per mil product in error. Following the standards, and to avoid these types of errors, best practice would be to always have a second person double-check both the calculations in the MFR against the original formula and the compounding file against the MFR. When listing ingredients, you must include quantities based off the expected yield. So in this case, we are using 100 grams as our expected yield, so 1 gram of hydrocortisone and 99 grams of clotrimazole cream would be required to make the 1% concentration. This section must also include a description of each ingredient, the source of the ingredients, and unique identifiers when available. Descriptions can be found in safety data sheets, but they can also just be a simple explanation of what you see when you look at the product. For example, white powder or thick white cream. The source is the manufacturer of the ingredient. Examples of unique identifiers are drug identification numbers or natural product numbers. For many compounding ingredients, the unique identifier is a CAS number, which is the Chemical Abstract Services number and can be found in the safety data sheet or on the ingredients label. You must also include any unique calculations specific to the compound. The calculations required for this compound are very simple. Expected yield in grams multiplied by 0.01 to get the quantity of hydrocortisone required, and the expected yield multiplied by 0.99 to get the quantity of clotrimazole required. When expected yield is equal to the quantity being dispensed for a particular prescription, the quantities in the MFR should match the quantities on the compounding record. If the quantity dispensed is different than the expected yield in the MFR, the ingredient quantities will be different on the compounding record, but the calculations in the MFR can still be used to ensure the compound file is set up correctly and the quantities listed are correct. An important part of the MFR is the section dedicated to special precautions to be observed by the compounding personnel. This section will include any risk mitigation strategies determined to be necessary when the evaluation of the compounding practice and environment was completed for that specific compound. This may include personal protective equipment, environmental controls, or other strategies to minimize exposure to staff. There should be documentation of the evaluation that was completed somewhere within the MFR, since this would be considered supporting rationale for determining it is appropriate to compound the product. In Module 4, I completed an evaluation of the compounding practice and environment for hydrocortisone 1% in clotrimazole cream and determined that, in my opinion, it is appropriate to prepare this compound in the dispensary environment. It is a simple compound using small quantities of non-hazardous ingredients, and risk can be mitigated with proper PPE. My evaluation determined that the compounder should wear safety goggles or glasses, a mask, gloves, and protective clothing such as a lab coat when compounding this product. Since this compound uses an ingredient in the powder form and there would be an inhalation risk, you could include minimizing foot traffic in the compounding area as a risk mitigation strategy and also ensuring an adequate ventilation system is in place. My guess would be that most pharmacies have a store ventilation system in place and would be considered an open, well-ventilated environment rather than a small, enclosed space. If this was a hazardous compound with ingredients listed on the NIOSH list, this section may indicate that a hood was required for compounding, unless the compounding supervisor could mitigate risks in other ways and the compound was made infrequently in small quantities. The MFR must list the required equipment for making the preparation. This should include anything used during compounding, and for this product, we would need a scale, weigh boats, an ointment slab or paper, a spatula, and an ointment jar for the final product. The mixing instructions or recipe needs to be included and can be written in a step-by-step format. This ensures that each time the compound is made, it is done so in the same manner, regardless of who is preparing it. For hydrocortisone 1% in clotrimoderne, the steps would be as follows. Step 1. Ensure the compounding area is clean and free of clutter. Step 2. Tare the electronic scale and weigh the required quantities of hydrocortisone powder and clotrimoderne cream using weigh boats. Step 3. Place hydrocortisone powder on the ointment slab or paper. Step 4. Using a spatula, levigate the powder with a small amount of cream. Step 5. Using geometric dilution, gradually add the rest of the cream and mix thoroughly to produce a homogeneous mixture. Step 6. Transfer to ointment jar and label appropriately. And finally, Step 7. Clean equipment and compounding area. Next, we need to consider the source of the formula and any references used to develop the MFR. There are several places we can find formulas for compounds. Some pharmacies may have subscriptions to compounding databases, but there are also free resources available, such as the IWK and Sick Kids websites, PubChem, and Mediska. When reviewing references for formulas, it is important to ensure that they are up to date. For example, if you look up the formula for Nadolol oral suspension in the IWK compounding formulas, the beyond use date is listed as 60 days, and the formula was revised in 2017. The only reference listed is the Hospital for Sick Children, and it states pending stability study. When you go to the Sick Kids compounding recipes, the Nadolol formula was reviewed in 2020 and the beyond use date is 91 days. This discrepancy highlights the need for you to do your due diligence and ensure you have the most up-to-date information. Sometimes you won't be able to find an original formula, and that's okay. I doubt anyone could find a reference or original formula for hydrocortisone 1% in clotrimoderne cream, but that doesn't mean we have to stop making it. We prepare many compounds with recipes or formulas where the rationale for use is based on long-term use and tradition rather than robust clinical evidence or published literature. So this just needs to be documented in your MFR. You also need to include a description of the final product and storage conditions, including the type of container that the final product should be transferred to. For hydrocortisone 1% in clotrimoderne, the final product should be a thick, white, homogeneous cream. If during verification, the final product does not appear as described in the MFR, it should not be dispensed, and there should be an investigation to determine what went wrong. A good example of a product that could look different is diclofenac and diffusemax gel. If a levigating agent is not used, pockets of powder can appear within the cream. When a levigating agent is used, it results in a homogeneous mixture with no visible powder. Storage conditions need to be included and will vary for products, but may include light-resistant packaging, refrigeration, or glass bottles. Every compounded product must be assigned a beyond use date in the MFR. This is the date after which a compounded product should not be used. The actual date assigned as the beyond use date must be documented as part of the prescription record and also included on the label of the final preparation. This is an easy step when there is published literature or referenced formulas, but many compound recipes or formulas used in the pharmacy setting do not have studied beyond use dates. However, this doesn't mean that we can no longer compound these products. When there is no stability information for a compound, pharmacy practitioners must default to the United States Pharmacopoeia Guidance on Beyond Use Dates, also known as USP 795. This information can be found in a table in Appendix E of the Standards of Practice. It is important to note that USP 795 is currently pending an update, so it's important to stay up to date on this type of information. For hydrocortisone 1% in clotrimodone cream, the beyond use date would be 30 days because when you look at the ingredients on the clotrimodone cream container, water is listed. It is important to consider if there is any reason why the dating listed in this table would not be appropriate for the product you are compounding. An example of this would be if one of the ingredients had an expiration date less than the beyond use date recommended by the USP table. Other examples of compounds that may require a shorter beyond use date are included in Appendix E of the standards. Unfortunately, there is ample opportunity for error when compounding in the pharmacy setting. The compounding supervisor is required to develop a quality assurance program specific to compounding activities to ensure the safety of the public. The quality assurance program must monitor training, adherence to policy and procedure, documentation, maintenance of equipment and facilities, and management of quality-related events and recalls. For the purposes of your MFR, you must include an explanation of any required quality control procedures. Some examples of quality control activities for hydrocortisone 1% in clotrimodone are verifying the MFR was current and reviewed by the compounder, double-checking calculations, and ensuring proper technique was used. Independent double checks of ingredients and measurements before mixing the compound should be performed whenever possible. An independent double check is when a second practitioner performs verification in the presence or absence of the first practitioner. The most critical aspect is to ensure that the first healthcare provider does not communicate what they expect the second practitioner to find. In other words, a second person checks the ingredients and measurements of the compounder. Another example of a quality control procedure would be visual inspection of the final product and label to ensure they match the description and information in the MFR. Some compounds may require pH to be checked, and this requirement would be included in this section. Each pharmacy may have different quality control procedures in place, and that's okay. Documentation of the results of the quality control procedures needs to be recorded on the compounding record for each individual prescription. These quality control procedures can catch errors after the MFR is developed, but before the product reaches the patient. There was an error that was caught in a pharmacy recently when a prescription was received for nifedipine 0.3% in Vaseline. They had no compounding file or MFR made for this strength, but they did have a file and MFR for nifedipine 0.2% in Vaseline. Staff used the 0.2% file and MFR as a guide to develop the 0.3% file and MFR. When the pharmacist conducted the quality control procedures and performed a double check on the calculations, they discovered that although the compound was named correctly as 0.3% strength, the quantities were not updated and equated to just 0.2%. Finally, if a practitioner decides to prepare a compound that is commercially available, they must include their rationale in their MFR. An example of this is dexamethasone suspension. There is a commercially available dexamethasone elixir, but it may not be appropriate for the pediatric population for two reasons. The product contains alcohol, and it's also a concentration that is very low, and the required dose would be a large quantity that many children may have trouble taking. The rationale for compounding would be to avoid alcohol ingestion by pediatrics and also improve compliance by compounding a stronger concentration. One might think that the final step in compounding is verification of the product, but verification actually needs to occur throughout the entire compounding process and not just at the end. Verification should include independent double checks whenever possible, and this should be documented on the compounding record each time a compound is dispensed. Appendix E lists the required information that must be included in the compounding record, and many items overlap with the requirements of the MFR. Some things that must be documented on the compounding record include verification of the MFR, an assigned internal identification number, for example, the prescription number, the date of preparation, the lot numbers and expiration dates of all ingredients, the total quantity made and dispensed, as well as the quantities for individual ingredients, the actual beyond use date calculated from the date of preparation, a record of calculations, and the results of quality control procedures. There must also be a spot to record who made the compound, who verified the steps, and also who approved the final preparation to be dispensed to the patient. Remember, we are standardizing processes and improving documentation to ensure patient safety during the compounding process. This is the end of the final compounding module, and you should now be comfortable explaining the difference between a compounding record and master formulation record, creating master formulation records, determining beyond use dates, and also have an understanding of the verification and quality control requirements when compounding. In closing, I think it's important that we reflect back on Module 1, where I introduced the standards of practice, and we heard from Melissa, who told her story about the tragic loss of her son, Andrew.